Yeah, good afternoon, good morning, everyone. My name is Nicola Brandt. I'm a regional child protection specialist with UNICEF Asaro, and on behalf of the regional learning platform on care reform, I'm really pleased to welcome you to today's webinar, which is focusing on case management for prevention. And the organization of this webinar has been led by Changing the Way We Care, which we greatly appreciate. As you've heard, the webinar is being recorded, so we ask that all of us kindly, when we're not speaking, that we mute ourselves. And if not yet done so, if you could please introduce yourself in the chat box, if you could please list your name, your country, and who you are working for. And just to note that exceptionally, today we do not have interpretation services as it was not requested by participants. So before we get to the webinar, just a few brief words about the Regional Learning Platform. It's a platform that was set up by UNICEF Asaro with contributions from Changing the Way We Care, and it provides an important opportunity for policymakers and practitioners from across Eastern and Southern Africa and beyond to exchange learning on care reform. We have regular newsletters and webinars, such as the webinar today, and produce policy papers, videos, and case studies. And very importantly, we also have a help desk, which allows anyone in the region from government or UNICEF to request support on care reform. And each month we send out a newsletter which contains a short 5-minute article that can give you new insights into an aspect of care reform, which also updates you on any progress in relation to care reform in the region and globally. So we really encourage you all to sign up to it. And this year, in addition to the webinars, we've also started interactive workshops. This was an initiative that we started in response to also the evaluation of the regional learning platform. So we had our first interactive online workshop back in June on care levers networks. And we're very excited that on the 18th of September, we will have the second online interactive workshop, which will be focusing on collecting data on children in residential care. So this is being done and jointly, particularly with UNICEF HQ colleagues that have developed relevant tools. So if this interactive workshop is of interest and you would still like to sign up, we ask that you please let us know in the chat box. You can also specifically email Bertha. And then finally, in terms of the regional learning platform, just to highlight a few recent resources that are also very relevant to today's discussion. So we recently launched a new paper on case management for care reform. That's available in English, French, and Portuguese. And there's also a new video on supervised independent living. So those are the two most recent resources. And to then now focus on, our very exciting webinar today, which, as mentioned, is focusing on case management for prevention. Really, the overall objective today is to share knowledge and insights that are based particularly from country-specific experience, specifically from Kisumu and Nyamira counties in Kenya, regarding case management for children at risk of separation. As mentioned, we really appreciate all the efforts that Changing the Way We Care colleagues have made to organize this webinar. Just in terms of the practicality, so you're aware, there will be 4 sessions. The first session will focus on case management for children at risk of separation more generally, and the second session will then very specifically focus on how Changing the Way We Care adopted and used case management for prevention. There will be a Q&A session following those 2 sessions, and then the remaining sessions will be on the lessons learned that Changing the Way We Care gathered from this case management process, followed in the final session by a panel discussion where case conferencing, bilateral referrals, and coordination by government to ensure delivery of quality services to children and families will be discussed. And this panel discussion, as well as the prior third session, will then be followed by a Q&A. But of course, we would very, very much welcome any questions that you have also before we get to these Q&A sessions. So really, please don't hesitate to place any questions into the chat box at any time. And also finally to note that there's a dedicated Google Drive folder for this webinar where you will then in follow-up to the webinar find all slides and all resources that will be referred to in today's discussion. So rest assured that you will have all those resources in an accessible folder. So with that, I'm really pleased to turn it over to Crispus of Changing the Way We Care, who will be taking us into the first session of the webinar. Over to you, Crispus. Thank you.
Thank you so much, Nicola, and thank you, Emily, for starting us off as well. I just want to first confirm if I'm audible enough, then I can introduce myself and proceed.
We can hear you perfectly, thank you.
Thank you so much for that confirmation. So I am Crispus Natala. I work with Changing the Way We Care here in Kenya as a case management for integration and prevention advisor. I have previously worked with Changing the Way We Care in the field in Kisumu County, to be specific, where we are drawing most of the lessons we are learning in this webinar. So as was shared by Nicola, the learnings are from Kisumu and Nyamira County, and we are glad to share these learnings with you so that we continue advancing the work around the world when it comes to protecting children and preventing them from separating with their families. So I think with that introduction, then we can quickly move into the content of the webinar so that we also keep allowing enough time to get questions and interactions with the participants. Just a moment for that to be set up, then we can proceed. Thank you so much for that, Emily. As was shared, indeed, this webinar focuses on case management for prevention, and especially how we use the case management for prevention standard operating procedure in Kenya to achieve what was planned as desired results for the families that were at risk of separation with their children. And this is a case of both Kisumu and Nyamira counties. We can move to the next slide. So case management in itself, if for those of us who are really practitioners in this, you'll understand that it is that process where we ensure that an identified child and family have their strengths identified as much as we are out to identify their needs for care, protection, and support. We do this to ensure that we then meet these needs and that the families are supported. It is typically that responsibility of an allocated social worker and the family or the caregivers working together with other professionals called in as you involve the child and the family in this process. And these key players will often jointly identify what are the protective factors and risk factors for family strengthening interventions. So just to elaborate a bit more, that the responsibility of case management is usually allocated to that dedicated social worker, who often meets with the child and the family and any other carers and professionals involved with the child to basically assess, plan, deliver, or even refer the child and family for services as is required. This caseworker will also monitor and review progress of the case to ensure that the child and the family needs are met to prevent separation of this child and the family. And this is done by addressing what have come as presenting factors, presenting risk factors through offering family strengthening interventions. So family strengthening itself refers to those programs. We can just stay on the last slide. Don't move, please. So family strengthening itself refers to those programs, strategic approaches, and the deliberate processes that empower families with the necessary capacities, opportunities, networks, relationships, and even access to services and resources to promote and build their resilience. when we speak of family strengthening approaches, we aim to identify any existing family strengths. Remember, families also have something to offer. So we are out to identify their existing strengths and work with the family to strengthen their ability to promote positive outcomes for all, and even avoid harm when the family is exposed to risk. Family strengthening approaches, therefore, can support the successful prevention of family separation or of free separation after integration. So in Kenya, the context was really unique for us. As much as we were out to prevent separation of children, we were alive to the fact that for those children that we had reintegrated back to their families and communities from the institutions, they also could undergo separation if nothing was put in place to prevent that. So that is another category of children that we were keen on trying to support as well. We can move to the next slide. So why did we opt to use this case management approach for families at risk of separation? We really thought that this case management provides that roadmap for improving child and family well-being, while at the same time it increasing accessibility to services. Case management ensures that families are secured enough to meet their needs, be they financial needs, protection, social, or even emotional health and education needs. But it is important to recognize, as much as I mentioned this, that no program can address all needs of the child and the families in need of support. As such, the goal for case management for us in Kenya and for those who practice case management will always differ slightly depending on the unique resources and parameters of each program. Similarly, children and families do not all have the same needs, and therefore the implementation of a unique case plan will vary in intensity by the number of home visits required by the community health volunteers or child community level workforce, as we refer to them, including the length and types of interventions that are offered to each unique family. Case management helps the family to build on those existing resources I had mentioned earlier and the strengths they have between the child and the family to help inform whatever decisions are arrived at about what actions the family can complete independently, as well as what additional interventions or services the client may require and who can provide these services at what intensity and for how long. So basically, that is the reason why we felt as changing the way we care, we need to adopt this evidence-based approach to support those families to achieve that state of well-being, focus on the stability, security, and resilience, and also to just ensure that as a foundation, case management ensures these children are healthy, they are safe, and they have access to education, economically secure families, and also it ensures that significant collaboration between the family, the children, and other stakeholders to build the resilience of these families that we are trying to prevent separation. So case management for these families at risk of separation is not only a good practice, but it helps to ensure that we have the coordination and linkage of services with other stakeholders, while also helping the families to identify and build on their own existing resources and strengths as much as we can come in to support them. So it is critical to use case management because it ensures that continuum of care and resilience building for the family and the child that are being supported. We can move to the next slide. So as we did this prevention of separation work in Kenya, we quickly came to realize that there were factors that were predisposing families to the risk of separation. And some of these factors is what I want to take us through from what we learned as lessons. These are the drivers of family separation. You will realize that they are not exhaustive. We can move to the next slide. They are not exhaustive as such, the drivers, but this is just to give you a glimpse into our world and what we encountered while we were trying to do this. So there are many different reasons why children and families can sometimes be separated and end up in charitable children institutions or other forms of care, or sometimes the children also end up on the streets. Separation may happen unintentionally during times of crisis, such as during conflicts or natural disasters that may be sudden, such as flooding or cyclones, or maybe chronic circumstances such as drought. Some factors that push children into alternative care, such as economic or other forms of stress or violence in the home, while other factors pull children into residential care, for example, the availability of education or active recruitment from available charitable children institutions within their locality. So from our experience, the following are some of the primary reasons or drivers of separation that the children are separated from their family and enter alternative care. We came across issues to do with poverty, abuse, neglect, and having a member of the household living with a disability, for example. But it should be noted that most households in poverty and most households in which there is abuse and neglect do not necessarily separate. So as much as these are factors that could expose one to separation between the child and the family, it is not often that anyone who falls under these categories will eventually separate with their children. Most households with a child or adult with disability succeeded in providing nurturing care, support, and protection, and there are often other underlying factors that may make it more likely to occur, and these are often when a family lacks sufficient protective factors to stay together and thrive. So if you look at the image, you'll realize that some of those drivers of separation, as I've mentioned, are disability, where you find within a household there is one caregiver or a member of the family who is severely disabled, and thus there is need to take care of them more often than not around the clock, and this will predispose any children within that household to the risk of being separated with their families. There is also the families that have the elderly or widowed caregivers, because more often than not, they can't really provide as they need to provide for their children or the grandchildren that stay with them. Where we have limited social support networks, there is a risk of separation as well. You find scenarios where you have many CCIs within a locality could provide that opportunity where there are those pull factors, for example, access to education and the likes, because of the availability of the institutions. Then violence at home is also a factor that really has to be considered, violence against children especially, and more often than not, we've come across children who have run away from their families in the past. So because they've done this in the past, then they are at more risk to again separate with their families if their needs are not well met or taken care of within their families. We could move to the next slide. So what are these protective factors that we explored as changing the way we care to prevent separation of children and their families? What is projected on that pie is some of the really considerations we gave as protective factors. And protective factors enhance the likelihood of positive outcomes and lessen the likelihoods of negative consequences when a family is exposed to risk or shocks. Changing the way we care adapted that guide to ensure that we really worked around these protective factors. One of those is caregiver resilience, which is on the left of the screen. I think the color is purple. And managing stress and functioning well when faced with challenges, adversity, and trauma. Social and emotional competence of children is another area. So with caregiver resilience, changing the way we care really supported families to manage stress and function well when faced with challenges, adversity, and trauma. Some of these could basically be instances where, for example, a dependable caregiver passes on and the child is left to be taken care of by other members of the family. So that has to be managed. Where one parent is left behind as the other tries to eke out a living, their resilience also needs to be supported. We had another protective factor in the form of social and emotional competence of children. Here we looked at ensuring that the family and the child interactions help the children to develop the ability to communicate clearly, recognize, and even regulate their emotions and establish and maintain relationships with other members of the family. The other protective factor could be the social support and connections. Here we were really out to ensure positive relationships that provide that emotional, informational, instrumental, and even the spiritual support that families and children need. Remember, when there is lack of access to this, then there is likelihood that the family could separate because there's no structures or pillars to support them in times of need. Responsive caregiving was another factor, and this is about understanding child development and parenting strategies that support physical, cognitive, language, social and even the emotional development of children. So once you have that understanding, you could use this knowledge to work with families around taking care of their children, depending on their age and even their evolving capacity. Then we have the access to concrete support in times of need. This is about access to concrete support and services that address a family's needs and help minimize stress that is caused by any challenges. So the importance really of family strengthening is seeking to enhance that likelihood of positive outcomes and lessen the likelihood of negative consequences when a family is exposed to risks or shocks by supporting the family to build up these 5 protective factors that I have just briefly spoken about. So I think with that, then that brings us to really the end of the first session. And we could move to the next session where we want to speak about how Changing the Way We Care really adopted case management for prevention SOP and tools in Kisumu and Nyamira counties. So if we could move to the next slide. Yes, so this is the second session. We will take you through that journey, how we adopted the case management for prevention standard operating procedure and used the tools in Kisumu and Nyamira counties. Next slide. Thank you. So family strengthening experiences in Kenya. We realize that Kenya is a pioneer in many family strengthening approaches, including the cash transfer to the orphans and vulnerable children, what we largely call in Kenya City OVC program, a government program. We have commitment to care reform and national commitment to prevention and response to violence against children as well within the country. Changing the Way We Care developed a standard operating procedure to guide the prevention of separation between children and family, and to ensure that these families were strengthened to realize what we felt were the key things that the families needed to prevent separation. And as you will hear later, Changing the UK is currently adopting the Changing the UK SOP as a national standard operating procedure as part of the National Care Reform, Family Strengthening and Prevention pillar, which is one of the 3 pillars in our care reform strategy. So just to emphasize that when we started doing this work, we came from a point where Changing the Way We Care really struggled with a high caseload, and we were looking out for information and resources to help us graduate or even close some of these cases, as we had supported them to the best of our ability, and in the process we had managed to prevent separation. It is on that background that we developed that standard operating procedure that could help us go through the process while ensuring that indeed we prevented separation as we hoped to do. We can move to the next slide. So I will briefly take you through the process of adopting the SOP that we used. And first, I would mention that this was a kind of, it is a process that took quite a number of years. And I will go back to 2022, sometime in the year 2022, when Changing the Way We Care had to define the family strengthening interventions. We had within the same year to also then take a stab at developing the SOP, the standard operating procedure, and tools that will support the delivery of those interventions using case management to the households that we had identified as being at risk of separation. In the same year, 2022, we developed the pathways and a layering approach for the delivery of interventions, including the guidance for safely exiting families from the project. And then at the start of the year 2023, Changing the Way We Care had the package and the materials to now train trainers of trainers, or TOTs. We trained the local implementing partner staff as trainers of trainers on this package. That is the case management for prevention package in January 2023. After about a month, we got to March 2023, where these TOTs later on cascaded the training to the community level workforce within the counties. And here, this is how we came to train quite a considerable number of workforce in Kisumu and Nyamira counties. And this was by use of the SOP and the tools, including the PowerPoints that we had developed, to manage the huge changing baby care caseload that we had. And as much as we did that, to also just bring in that culture where we focus on prevention of separation of children and families, and not just respond to those that had already separated and were in institutions. Later in that year, March 2023, we did testing and utilization of the SOP to support case closure in Kisumu and Nyamira. So we developed a flowchart guidance for the reevaluation of households that were at risk of separation. Case conferences were held and were used during the process and at the end of the case, at the end of the cases, and as required during the course of the case. So at any interval where it was important to use the case conference, that was an opportunity for us to employ that important part of the process to ensure that our cases were managed well. So eventually we shared lessons that Changing Baby Care had learned with the government, and then this led to the eventual adaptation to have a national family strengthening standard operating procedure. I will explain further towards the end of this discussion. So I will leave this at that, where we just went through the process. And from March 2023 to the end of that financial year, we used this package and the SOP to manage the huge caseload that we had, to ensure that actually we graduated our families out of the program. We could move to the next slide. So these are the three pathways that Changing Baby Care really had as part of that SOP. And what you see towards the left is one of the pathways that we had of managing the cases that we had to prevent separation and even strengthen families. Towards the center is another pathway, and on the far right is the third pathway that is basically referral for services. And this is that opportunity for us to refer families to where they can actually get some services that Changing Baby Care itself was not providing. We identified beneficiaries and families based on our context at the time. Changing Baby Care adopted those three pathways like I have mentioned. First pathway was about children who were currently in institutions or of care and who had been supported to reintegrate. Remember, I mentioned we worked with children that had left institutions of care and went back to the community or to their families. So there was still the need for us to continue supporting these children and families just to prevent re-separation, which will maybe end with them getting back to the institutions or even to the streets. So when we used that pathway, we really ensured that these children that had initially been identified and supported through the Government of Kenya Case Management Guidelines for Integration, that they were living in a family-based setting, and the child and the family were benefiting from the family strengthening services that could be extended to them, which would eventually prevent the separation or re-separation of those children. Then Changing Baby Care also had another category of families, and this is the second pathway. And these are the families that had already been identified and enrolled in existing community or household interventions. There are those that were already going through some group interventions within Changing Baby Care, and these were identified as at risk of separation and were thus benefiting from a package of family strengthening interventions with the aim of preventing separation. Some of these packages that they were benefiting from include the positive parenting or group, which was offered in group or individual sessions. And we also had financial literacy sessions for these families. We had savings and loans and other forms of financial support towards these families. We also had life skills training and other forms of psychosocial support. We deliberately ensured there was disability inclusive interventions, which includes community-based rehabilitation for these families that needed that service. Then there was the focus on early childhood development and healthcare resources. For example, Changing Baby Care went out to provide medical insurance, annual medical insurance for the families that we supported so that they could access medicine or health-related services when they needed them. Then there was the social assistance transfers, for example, education bursaries. We will give cash transfers and sometimes kitties to just ensure we push on families from that lack that they will go through that will maybe end in separation. And lastly, like I mentioned, we had the bidirectional referrals or linkages to service providers where there are certain services that we could not provide. For example, there are categories of families that we will send for referral to get assessed for disability, so that then the assessment would inform us what their real needs were, and if it was about an assistive device, what was the appropriate assistive device for this family, so that we could then get them what will help meet them at their points of need. So lastly, the other pathway that I mentioned, these are children and families that were identified as facing particular risk of separation and who would be referred to Changing the Way We Care and other local family strengthening service providers for support. For example, this might have been direct referrals that we got from the children's offices in the 2 counties. We had charitable children institutions or local gatekeeping mechanisms in place that were working. Even child protection committees could sometimes refer cases that, if we did not intervene, could then face the risk of separation. And when these were identified and referred to us, that is how we enrolled them to our program through the 3rd pathway that is on the right, the SOP 5.3 that was for referral. So what is in the middle is the pathway that supported families that were undergoing reintegration to help prevent separation. And what is on the left is what is those families that we already had enrolled within Changing the Way We Care in different forms of group interventions and getting interventions that I have just spoken about. Good, so those were the 3 pathways that we used. We could move to the next slide where I will take you through again, a brief recap of how we used the SOP to manage the caseload that we had. Remember, I mentioned that Changing the Way We Care had a high caseload. We worked with over 1,700 households in Kisumu and Nyamira counties. And of these 1,725 households, eventually Changing the Way We Care managed to support 1,063 cases in Kisumu, while 662 cases were supported in Nyamira County. So this is how it looked like for us, how we managed the caseload using the SOP. We defined defining contextualized red flags that support the identification of families at risk of separation during universal and group-based interventions for support through case management. So while these families were going through the interventions in the groups, the facilitators were trained to identify what we call red flags, that in case we did not come in to support, then those families could end up being separated. As much as we did that, we also ensured that we managed the caseload through the 3 pathways that I just mentioned, while emphasizing on identification of protection concerns and imminent separation concerns for adequate support of the families that were under our care. We also ensured that the community level workforce were supported to identify cases that were ready for closure and those to be reassessed by the local implementing partner social workers. I mentioned we worked with a local implementing partner in Kisumu and Nyamira. This was ICS, Investing in Children and Their Societies. And this partner really helped us to get to the communities and to the families to ensure that we worked with this workforce to meet their needs. We also had to come up with a flowchart, which we utilized. I will go through that flowchart briefly in the next slide. We utilized that flowchart as guidance to enable reassessment of families at risk of separation before we validated the caseload that each community level workforce had. Lastly, we also used case conferences, and we held case conferences for the case workers to present their cases to the case managers. And the managers in this case were the Directorate of Children's Services, children officers, and even the LIP staff that were within those vicinities to agree with the recommendations of the case workers before we could then proceed to case closure process that was determined by the discussions within those case conferences. So as I summarize the slide, I will just mention that of the 1,725 households that Changing the Way We Care had, using this case management for prevention SOP and tools, we managed to responsibly close all these cases. 1,438 of them were closed by achievement of the set case plan goals, while 64 of them were closed through case transfers. And we managed in the process to refer 18 families for extra services that were not available to changing the care, while 205 of these cases were as a result of attrition. That is what led to the closure of those cases. And by working with the local implementing partners, we could estimate that the average case load distribution for each local implementing staff was about 20% of the overall caseload. So the local implementing partner in question had around 5 social workers. They had a meal officer and a project coordinator who would then support 56 community level workforce that we had supported and trained to ensure that overall we managed the caseload to ensure that all the intended objectives were met for those cases. We could move to the next slide. So I will finish by just mentioning that this is the pathway I referred to in the previous slide. It is a glimpse of how we manage the cases, and we ensure that at the first step, the community level workforce got to list all their households. I mentioned they worked with about, the caseload was about 50 or thereabouts for each workforce. So they would list their households that had been allocated to them and help us identify those households that were ready for graduation and those that needed reassessment. Once that was done, Changing the Way We Care will then validate this with this information from the case workers. And this was done by the local implementing staff social workers, who referred to the case plans and the assessments that were within the files that were in their offices. Then we held case conferences with the Directorate of Children's Services, where case workers presented, the community level workforce presented their cases and recommendations, whether the case was ready for graduation or it needed reassessment. We would then graduate and close the cases that were ready for closure by filling out the necessary tools, while those that needed reassessment, we would send out a team to then go to the communities and reassess these households just to check where there were still risks of separation or other concerns that would prevent the cases from being closed. Where those risks were still identified, then we ensured that we provided what needed to be provided by updating the case plans of these families and meeting their needs before we could then move to the last step, that was the exiting or the closure of the cases after the process had been done. So once we had exited and closed the cases, the mill officers helped us to update the case management databases. Where exits were done, all cases were exited, and the right tools used to update the progress of the case. I would leave it at that as a summary of that pathway and how we approach the process. And at this point, just to invite, I think at this point, I would invite any question or check on the chat if there's a question before we can proceed to the third session where I would invite Macrin. So is there maybe any question that I could respond to on the chat in about 2 minutes before I invite Macrin?
I don't think there have been any questions in the chat so far, but if anybody has one, you can also just raise your hand and ask the question directly. Okay, I don't think there are any additional questions. Maybe we can proceed.
Thank you so much. In case there are any questions, feel free to post them on the chat, or we'll give another opportunity for questions as well as we proceed with the session. So I think that brings us to the end of the first session, like I mentioned, and that is a session that took us through case management in general and narrowing down to case management for children at risk of separation. I then eventually shared with us how we adopted, that is Changing the Way We Care adopted and used the case management for prevention SOP and tools to manage the cases in Kisumu and Nyamira County, where I took you through the 3 pathways to prevent separation and how we manage the caseload, the nitty-gritties of the process that we use to manage the caseloads themselves in Kisumu and Nyamira counties. For the third session, I want to invite my colleague Macrin to take you through the lessons that Changing the Way We Care learned during the case management process, using the case management for prevention SOP, and tools. So she will have 10 minutes to take us through the session 3 before we then get to a session with the panelists. So welcome, Macrin, so that you can take us through that third session.
All right. Thank you so much, Crispus, for taking us through session 1 and 2. My name is Macrin Otuge. I work with Investing in Children and their Society as a project coordinator. ICS, our focus is around family strengthening and child protection. And I will want to take us through the lessons learned through the process. During that process of ensuring that we prevent separation of children from their families. So there were so many lessons that were learned in the process. And just to mention, before I talk about the key lessons that we've shared on the screen, one of the key lessons, some of the things is the community level workforce, or I can say the caseworkers were generally happy when it comes to the positive response and feedback that they got from the caregivers and from the families that were being supported. And also with the feedback that we got in that process, it informed also in terms of how we could do things better, on how we could also improve on support that we are providing to families at risk of separation. So one of the key lessons that we learned in the process was the community level workforce is very key. So we're looking at strengthening and engaging this cadre. So when we talk about community level workforce, we are talking about community level workforce that or community volunteers that are attached through the government. So they are through the government structures, and specifically we worked with the child protection volunteers and also the lay volunteer counselors who are attached under the Directorate of Social Development, and child protection volunteers attached under the Directorate of Children's Services. So strengthening and engaging this cadre is very vital, and for effectively supporting families and also at risk of separation. So engaging and building the capacity of the community level workforce is very key in this process to facilitate support to families at risk of separation. This is to ensure that the right information and support is provided to the appropriate families, and also that the graduation of the group intervention is and individualized support is delivered. So when we are able to capacity build, because these are the structures that we are using to also to deliver group interventions, it also smoothen the process of graduating parents in group intervention, and also ensuring that individualized support through monitoring visit, through one-on-one engagement with families. Then also community level workforce, they have remained to be the community resource persons within the communities, and also they continue to support families in the absence of even changing the way we care. So within this span of years, the span of 1 year since we changing the way we care stopped direct implementation in the community, these families are still being supported because by the community level workforce, because these are cadres within the structures of government, and also they are within the community, and they are the community level work. They are the community resource persons. Secondly, the targeted support. Targeted support as a lesson is very accurate in accurate targeting is essential to identify and to address specific needs. So not all families needed individualized support. So through the case management process, so because from the understanding of what Crispus has shared, when we talk about case management and what we mean, case management allows for individualized support for the families. But through case management of prevention, we not only support families at the individual level, but also supporting families and children, families or parents within groups. So appropriate targeting, therefore, is key in identifying families at risk of separation, and also to avoid general support extended to vulnerable families. As you saw in the previous slides where we were where Crispus talked about some of the triggers of separations. So through this process, we were able to identify what were some of these triggers, and also we were able to have accurate targeting of families. Then thirdly, integrated services is a key lesson where we combine group-based services and with target case management, enhanced support to caregivers, and find cash plus services more effective than the cash alone. So one of we learned that when we layer group-based intervention and also with targeted case management support, it improves outcomes to families. Unlike if we support families with cash transfer alone. For example, caregivers reported that their participation in group-based interventions like parenting improved their family relationships and overall communication within the households, and that the cash support alone is not sufficient when we are talking about family strengthening initiatives. So we need to have this group intervention we combine with cash for it to be effective within the families. And also we can say that also families, they recommended that future interventions required wholesome support and also programs that can build families before providing individualized material support. So it means that when we are looking at interventions for integrated services for families, we need to consider first, what is it that is building the capacity of families? And also then now we focus, then we go now to the individualized support. Looking at the flow or the pathway, when we are talking about case management for prevention, you realize that based on that process, the group interventions come first, and then we go down to families to provide individual support. And then also another key lessons that we learned was data utilization. So data help changing the way we care, and Directorate of Children's Services to identify the eligible families for Inua Jamii. So availability of data made it easier for changing the way we care to eventually support Directorate of Children's Services to identify eligible families in the demonstrating counties and linking them for the Inua Jamii support. I can mention that the data was available in form of a database where we have the list of families that were documented who are at risk of separating, and also the pathways. Also, we had the hard copy documents which were filed. So this made it easier to identify family and eventually referring them for Inua Jamii support. So also, just to add on, also when we are talking about targeting family, it is key to also to identify families at risk of separation with their children and avoid general support of the vulnerable families. And also, just to add another lesson was supportive supervision is also very key in this process because as we talk about capacity building, also working with the community level workforce, it is key to capacity build the community level workforce, and also it is very key to ensure that we provide support supervision. So support supervision is just technical support to the case workers, because it's very critical. These are people who handle, as Crispus mentioned, these are people who handle caseloads, and each person or each community level workforce or caseworker had like a caseload of 50 caregivers or parents or families. And also looking at from the onset of, from the inside of LIP, for example, the organization I work for, ICS, we were the local implementing partner. We had 5 caseworkers or social workers, and each had like 20% of the caseload. So it was indeed important for us to have support supervision to ensure that the success of case management process is looked into, and also to provide that support because they need support, and also they need support to be able to support those families better. So those were some of the key lessons that we learned through this process. So on to the next slide. So in conclusion, if we talk about case management for prevention, we can talk. Yes. So case management for prevention of separation, it has proven to be effective strategy in preventing separation and strengthening of families in Kenya, particularly in Kisumu and Nyamira County. Because looking through, we had like 1,725 caseloads and about 1,400 cases were closed successfully. So it's an effective strategy when we want to prevent separation of children. It also has underscored the importance of community level workforce engagement and capacity building, which has facilitated the delivery of targeted support to families. Looking through that, we worked with the workforce, and also it has illustrated that the critical role of tailored interventions and the potential for sustainable family support system when properly implemented. So as Kenya continues to advance care reform, the lessons learned from the case management for prevention approach is still invaluable in approaching the future effort to protect children from separating from their families. So thank you, and over.
Thank you so much, Maclean, for taking us through that. I would wish to then take us to the next session. And this is a session where we have with us a few invited panelists. We want them to really help us get beyond what we have shared to just understand a little bit more of the experiences, highlighting the significance and impact, for example, of case conferencing, bilateral referrals, and even coordination by the government that eventually ensure the delivery of quality services to children and families. I would want first to just take a minute to introduce them, then I will give them an opportunity to respond to a question. First, I will want to introduce a gentleman by the name Kaisa Bernard. If you are okay, Kaisa, you could maybe just have your video on so that the participants can get to relate with you. Kaisa Bernard is a project officer within the Changing the Way We Care project. He is based in Nyamira County, and Kaisa Bernard has over 12 years of experience in community service and child protection work with a background in MBA. He has an MBA in project management, as much as he helps us with the work within Nyamira County and also Kisumu. So that is the first panelist we have, that is Kaisa Bernard. I will introduce the next panelist. I just want to check if we have Kaisa with us. Kaisa? Is Kaisa in?
Yes, Chris. I'm in, and I can hear you.
Thank you so much, Kaisa. I now want to introduce the other panelist. This is Maclean Otuge. Maclean has already been sharing with us. She shared the previous two slides. And Maclean Otuge is a social worker by profession with over 8 years of experience working with families, children, and communities. She has vast experience in child protection work, family strengthening, adolescent programming, care reform interventions, and other community engagement interventions. Maclean is currently the project coordinator. This is project addressing child labor with a focus on child in domestic work at Investing in Children and Their Societies, ICSSP, as she had mentioned earlier, as her organization. So thanks, Maclean, for being with us. Lastly, I just want to check if we have Martha Mbatia with us. Martha Mbatia has a master's in development studies. She is an assistant director of children's services with over 17 years of experience as a child protection practitioner. She is a certified trainer of trainer and Kenya School of Government adjunct lecturer. Martha is currently the sub-county children officer in Borabu, Nyamira County. Just to check whether we have Martha with us.
Chris, I don't think we do. I don't think we do have her with us. I can't see her on the list of participants. She's probably got connectivity issues.
Yeah, most likely, but we will see. If at any point she joins us, we will appreciate to have Martha with us. So I have a few questions that I would like to pose to the panelists, but just to request that if at any point any participant has a question that you would like our panelists to respond to, feel free to put that question on the chat so that they could help respond to it as well. I will first start with a question directed to Kaisa Bernada. And I think, Kaisa, I would want you to really just help us understand, with your vast experience and with the work you've done with Changing the Way We Care, how did Changing the Way We Care exploit the use of case conferencing to get significant outcomes and results while managing the huge caseload that we had as we tried to prevent separation of children from their families? Over to you, Kaisa.
Yeah, thank you so much, Crispus. Can you confirm if you can hear me from your end?
Loud and clear, Kaisa.
Yeah, thank you, Chris. And I am going to build my presentation based on the work you have already presented and Macrin. Just to begin from where Changing the Way We Care, together with the government, supported in training of the community level workforce, that is after the TOT training. And that was done in March 2023. And Crispus, you have already indicated that it is true indeed, we had a very high caseload in the count of Nyamira and Kisumu. That is, we had 1063 cases in Nyamira, in Kisumu, sorry, and 662 cases in the county of Nyamira. So after that training of the community level workforce, together with the officers from the Directorate of Children Services, that is in the month of March 2023. Remember, we had an ambitious task ahead of us where we were required to responsibly close all the cases by 30th June 2023. So we had a period of about 4 months to do that work. So at the end of that training, once the community workforce understood the concept and the graduation pathways, each of the community and based on the knowledge that they had gained at the end of the training, they were required to categorize their households into 2 categories: those whom they felt the households were ready for graduation, and those ones which they felt were supposed to be reassessed. So after that, the community level work.
We're losing.
I don't know if it's just me. Yeah, we are losing you, Kaisa.
Yeah, maybe
we are losing you, Kaisa.
Maybe Kaisa can just switch his video off. That might make the connection a bit stronger.
Yes, please. Then you have a bit, 1.5 more minutes to summarize.
So you can hear me, Chris?
We can hear you. You have 1.5 minutes to summarize.
So that was followed by a meeting at the LIB office where the community level workforce they shared their list for validation, of course, with the social workers and the LIB project officer. And they were making reference to the case plan and the assessment forms. After that process was concluded, now we convened for a case conferencing meeting at the county level, where the team, now the LIB social workers and the community level workforce, were required to present the cases of the household which were ready for graduation and those ones that were supposed to be reassessed before the case managers, in this case who were the sub-county children officer and the LIB staff. After the deliberations of those cases, each community level workforce, of course, was required to take the team through about their specific cases under the 2 categories. Then at the end of that meeting, there was an agreement. The meetings were done at the county level. We did minutes, which were done at the sub-county level. We agreed that minutes were supposed to be done at the sub-county, of course, clearly indicating the participants who attended the meeting, ranging from government, changing the way we care staff and the community workforce. And at the end of those minutes, the community level workforce, the social workers from the LIP, and the respective sub-county children officers were required to sign as part of ownership about the process. So after that, those cases of households which were categorized that they were ready for a graduation, the community level workforce were required to work with the LIP social workers where they filled the case closure forms, and they worked closely with the mid officer at the LIP level to start that process of closing the cases at the database. The other cases which required reassessment and the case planning, reassessment and case planning was led by the LIP social worker, of course, who was being accompanied by the community level workforce who could book appointment with the household so they could go together with all the necessary case management tools. They do reassessment. If the results came out that the household required case planning, that is what they did. And there are some instances where they established that such kind of families which were proposed by the community level workforce for reassessment were ready for case closure. So they recommended them for case closure. So after case planning has been done, now the final stage was to update, of course, the case management database, where exit of all the closed cases was done, updating of the database, especially where reassessment was done and the new needs were established and a case plan done, so that information had to be updated in the case plan. Then, and the responsibility of that role was the project coordinator and the mid officer of at the LIP level. So basically, that is the process we went through. That is the process we went through to responsibly close all the cases. So as at the 30th of June, we were able to responsibly close all cases, as Crispas has already highlighted. He gave a summary how many families we closed the cases through case plan achievement, case transfer, referral, attrition, and so on. So that is what we managed to do within that short period of time, a record period of 4 months, and we managed to responsibly close the cases through working together jointly with government and LIP staff and the community level workforce. Thank you, and over to you, Crispas.
Thank you so much, Kaisa, for that extensive elaboration of how the process was managed and specifically how case conferences were used to ensure that the closure of the cases was done as responsibly as it needed to have been done, despite us having a short period of time and the huge caseload that we had. So thank you so much for that. In case there's any other question that will come on the chat that is addressed to you, I will then just alert you so that you can help us within the time that we have. I will then take this moment to welcome Martha, but first let me pose a question to Macrin before I introduce Martha again and ask her to help us respond to a question. Macrin, this question goes to you. As a local implementing partner, like you mentioned, working with ICS and directly implementing the Changing the Way We Care initiative in Kisumu and Nyamira counties, taking lead in preventing separation of children from their families, how did you approach bilateral referrals, and how important was this to you as a local implementing partner and the families that you served? I will give you around 2.5 minutes to help us respond to that. Over to you, Macrin. You are muted, Macrin. We can't hear you. Please unmute.
Right. Okay. Thank you, Crispas, for having me again. As we see, referral is a very important pathway when we talk about case management for prevention. And referral is all about collaboration. How do you collaborate with other organizations? How do you collaborate with government departments, and also how do you collaborate with the community? How do you build that relationship? So one of the key things that we did, we worked together with the community level workforce, and we were able to map different service providers. And this ensured, and through this, we were able to document and update a service referral directory. So we, through that, we mapped in each and every sub-county. We worked in two counties. So in each and every sub-county, we had a service directory that was updated that indicated each and every service provider. So that was one of the first process that we did to facilitate referral. And then also we worked with the community leaders like Ngao, that is the national administrative officers, going down to the chiefs, assistant chief, to identify the locally available referral opportunities. And we identified the needs. For instance, in one of the sub-counties, we had an organization that was supporting widows. And also through their support, through the community leader, we were able to refer some of the families, especially who needed service, who needed such kind of service that the organization was offering. So this was facilitated through the support of the chief in that area. And then also we were able to document the referrals by ensuring that the completeness of the referrals. So we use technique like, for example, we had scenarios where we could refer families to services, and they sometimes they could not reach. For example, we had one case where a family was referred to a nutrition service and they did not seek that service. So based on that lesson, to ensure that we had completeness of documentation and referral, we used techniques like accompanying referrals, that is ensuring that the community level workforce accompany the caregiver to the service and actively advocate for services on behalf of even the caregivers themselves. So, for example, that the one caregiver that we were able to accompany to a nutrition service, they were able to get that service. We were able to build the relationship with that particular institution. And then again, we were able to take advantage of the group referrals. There are those services that needed group referrals. For example, in scenarios where we had a caregiver that require a service or a group of caregivers requiring services like birth registration, issues of disability, we did group referrals. For instance, in SEME, we did a referral that we call group referral through the mass registration on disability that was done in SEME. In most of the scenario, we did the integrated community outreaches where caregivers were able to get services in groups like services for birth registrations, education on issues around national insurance services. And lastly, documentation and reporting of referrals. When it is not reported, we say that when it is not reported, sometimes it's not done. So we ensure that we had documented, they were documented, and we use referral booklets. And the referral booklet was in triplicate, and through that, one, we ensured that a caregiver had a copy. We ensured that one, the original, we take to the Directorate of Student Services who was spearheading this process, and one referral copy also remained at our offices where we were able to file and also refer to that aspect. So through all these processes, these are some of the key processes that help us to ensure that we had bilateral referrals which were successful. And referral was also an important because as changing the way we care, we could not offer all the services, but some of these key services required referral. So it was an important process and step for us, and we ensured that each and every family that required a service, and based on the relationship and the collaborations that we built, they were able to provide it with these services. Thank you, and over.
Thank you so much, Maprine, for the comprehensive response to the question on referrals, including helping us understand a few techniques that you used that included accompaniment and even service advocacy, plus making use of the group referrals where you invited service providers to the community where these caregivers were. So thank you so much for that. At this moment, allow me to once again introduce Martha Mbatia, as I welcome her to respond to a question. I mentioned already that Martha has a master's in development studies. Martha is an assistant director of children's services with over 17 years of experience as a child protection practitioner. She is a certified trainer of trainer and Kenya School of Government adjunct lecturer. Martha is currently a sub-county children officer in Borabu, Nyamira County. Welcome to the call, Martha, as I pose a question to you that you will help us get a response. So, Martha, the importance of government providing leadership and goodwill to partners cannot be overstated. This is especially so when taking care of children in their families and communities. How does the government ensure service delivery is coordinated and all state and non-state agencies are working towards the common good while ensuring the best interests of children are taken care of while delivering quality services to them? I hope you got the question, Martha. Over to you.
Yeah, thank you so much, Natala, for that introduction. Well elaborated. And yes, I did get the question. And if you allow me, in the interest of time, I'll just go direct to the response. And one key thing that you realize is that when we are all doing this, our focus is the child. And as we put our focus on the child, we get all these services from various service points. It could be different line ministries, government departments, different players and partners. And so you realize coordination is very key. And one of the ways that the government ensures that that coordination is achieved is through coming up with registrations. For example, the laws that we have, the policies that we have. The government also develops the guidelines and the frameworks which guide how we offer our services to these children and families. And one of the key things that I saw was of great help. When I joined, I found Kaisa elaborating on case management, and you realize there is already a guideline that guides how we do case management for child protection in Kenya. And all these, the policies, the laws, the guidelines, the standard operating procedures, they streamline service delivery, and they ensure that regardless of where you are operating from, you are reading from the same script. Then the other thing that the government does to ensure that at least there is that kind of coordination is the workforce recruitment. You realize that we need the workforce, and this workforce is drawn both from the government departments, and many times, especially when we have been implementing care reforms within our county, we really tapped a lot from the community level workforce. All this workforce require, one, to be recruited in the first place. And then again, after being recruited, of course, they require their capacity to be built. And now when that is being done from a central point, you realize that even if you're coming from, for example, now, like the community level workforce, you have a pool of the lay counselors, then you have a pool of the protection volunteers, what we call the CPVs. You realize that they are coming from different departments. But when you now come together as a community level workforce and your focus are those children within those families, then you train them. you build their capacity. And the beauty of this workforce, especially the community level workforce, is that they remain within the communities, even as we transition some of these initiatives that are initiated by the partners that we collaborate with. Then the other key aspect about coordination is the political goodwill, because as much as you coordinate these things and you do not have a political goodwill, it will be very hard for you to operate. And you realize for our situation, especially here in Nyamira, we have had the great advantage of having that kind of seamless collaboration between both the county government and the national government. And the political wing comes in very handy, even as you think about issues of registration, because this happens either in the county assemblies or in our national parliament. And without the political goodwill, it will be very hard. It will not even be very hard. It will be impossible for you to registrate the policies, the laws that help bring some kind of sanity within this space of coordination. And then when this coordination, the other thing that helps coordination to come out very well is the establishment of the implementation structures. And I can give an example of the CACs, the Children Advisory Committees that run actually from the national level up to down there at the ward level. And you realize these implementation structures, they have this multi-sectoral kind of membership. And we draw from the various partners, not only the government line ministries, but also both the state and the non-state actors in this space of child protection. And that becomes very key when you are meeting in one space with an established structure, and you are coming on board on a round table to bring your resources together, and you channel them towards this one agenda. For example, strengthening the families that we are working with to ensure that these children are remaining within those families. And then the other very key thing about coordination is that when that coordination is done the correct way, then the government is able to ensure sustainability of these efforts initiated by the various partners within this space of child protection. And when this is done, you realize that we are able to advocate even for resource allocation, especially through budgetary allocation. And you realize now this happens both at the two levels, both the national government and the county government, because as much as we are saying that this docket of children's services is not devolved, but the Children Act in section 61 and 62 gives a role to the county government. And that has been very key for us, especially in Nyamira County, because we've been able to take advantage of the laws that we have, like the Children Act 2022, take advantage of that section and the law that gives a mandate to the county government, and make sure we come down to our level and even registrate at this level and come up with the Nyamira child policy. And now using that, it can be able to help us push the county government to have some budgetary allocation. And at the end of the day, because we have these implementation structures that we are all meeting, and that then coordination becomes very easy. And at the end of the day, who gains? It is the child who gains. Thank you so much.
Thank you so much, Martha Mbatia, for creating time and for responding to the questions. Thank you to all the panelists. I want to really appreciate you. And as I do that, I just want to draw our attention to a bit of a few minutes left on the call. I am glad we have one question on the chat from Catherine Kimodo. Thank you so much, Catherine, for finding time to participate in this discussion. I will read the question aloud, then we can just have a quick response to the aspects of the question that we can respond to now, and maybe have a follow-up response later after the call. So Catherine is interested to understand. First, we appreciate your compliment, Catherine. did we manage to document the budget implication of the process? I assume this is the case management for prevention of separation of children and their families process. And for purposes of influencing budget for sustainability and scale up to other counties. And how are these wonderful lessons being shared at policy level of government? Thank you, Catherine, for that question. As I take a stab at trying to respond to this, considering that I know my panelists, we were working with a bit of time with them, and we just have 5 minutes left on the call. Let me do just a quick response. We have managed to use the lessons that we have actually shared on this call to influence government. And you will see this as we move to the next slide of this presentation. The lessons that Changing the Way We Care learned, together with other partners, and especially UNICEF for support in Kisumu as well, helped us to actually have a sitting with the government. We took these lessons to the Directorate of Children's Services at the HQ level. Once we had these lessons shared with them, they saw the need for the country to actually have a national standard operating procedure when it comes to family strengthening and prevention of separation of children from their families. It is from that good work and the lessons that we shared that we have had sessions already with the government. And part of those sessions culminated in a whole week process we had last week in Naivasha with the government. This is representation from different departments within the Directorate of Children's Services and other state agencies that then came together to actually craft a national family strengthening standard operating procedure. We are glad that it is as a result of these efforts that very soon the country will have a family strengthening SOP that will help any practitioner beyond changing the way we care that would love to advance their work strengthening families and preventing separation of children and their families. So I think that is one massive gain we have already realized, Catherine. We have had discussions and we really thank your support in trying to push this agenda together as we engaged government, because it has borne that fruit where we are saying very soon we will have a national family strengthening standard operating procedure that will guide the work we do across the country when it comes to family strengthening and prevention of separation. What about the budget implications for the process? I would like to mention with an abundance of caution at the moment that we have managed to just, as Changing the Way We Care, try to host case management for reintegration itself, but we haven't gone further to cost case management for prevention of separation of children and their families. We are hopeful that maybe the learnings from the costing work for the case management for integration bit could be applied to even try and help us get a sense of how much it would cost to prevent separation. But that notwithstanding, if that costing is not enough, it is not yet out there for sharing. But if that won't be enough, then there would be need for an effort to really cost the work around prevention of separation and strengthening of families, because as you put it, it is important, especially when we want to influence allocation of resources and for sustainability and scale up to other counties as well. So thanks, Catherine, for that question. It was the only question we had on the chat. And because we have a few minutes, just around 2 minutes, I will wind up with the last slide and hand this over back to the moderators. So we could just go back to the last slide before I hand this back to Emily. What next? I think the question from Catherine came at a good point. So what next for the country when it comes to family strengthening and prevention of separation for children and their families? Changing the Way We Care, like I mentioned, we shared lessons with government officials. The government convened meetings where we discussed with other state and non-state actors to understand family strengthening implementation practices. And it was agreed that the SOP will be adapted, the Changing the Way We Care will be adapted. Last week, we had a workshop that we reviewed and contextualized the SOP. And it is through that workshop that we now are going through a process where we are going to prepare the final version of the national SOP and the roadmap that was agreed upon during the workshop last week. We have a few next steps to take, and we are really grateful that with all the support from everyone, adaptation of this prevention SOP and tools is now a reality, and it will be a national document soon, which is our biggest success. So I want to leave it at that and thank everyone for taking their time to join us on this call. I would really want to take this back to Emily because I am aware that we are now on top of the hour in terms of our time. Emily, back to you, and thanks for the opportunity.
Thank you so much, Crispus. I'm actually going to hand over to Nicola from UNICEF Asaro to wrap up the webinar. And while Nicola's speaking, I'll maybe just launch a quick poll so that we can find out who's on the webinar. So if people can complete that while Nicola's speaking, that would be fantastic.
Thanks so much, Emily, and thanks so much, Crispus. As was mentioned actually in the chat box, you're really an amazing webinar facilitator, so thank you so much. And a big thank you to the panelists. It was a very interesting exchange and really some key takeaways. I thought the particular focus also on the community level workforce was essential, the emphasis on tailored interventions, and it was very meaningful to hear your reflections on the significance of case conferencing, referrals, and coordination by government, particularly the mention of this essential component of political goodwill, also with a view towards sustainability, and very key questions also in regard to ultimately perhaps needing to also cost family separation. And of course, congratulations now on the National Prevention SOPs. So really fantastic. And as Emily was saying, we would be super grateful if you could please complete the short poll on the meeting. We have now run out of time, so we won't be able to share results, but completion of the poll is really helpful to us. And just to mention, the interactive workshop on the 18th of September that I had mentioned at the beginning on collecting data on children in residential care, please do reach out to Ismail if you are interested in joining. And to note that our next webinar will be taking place in November and will be focusing on children with albinism. It will be linked to the report that the independent expert on persons with albinism will be presenting in the General Assembly. So once again, thank you so much for today's engagement in the webinar. As mentioned, there's a Google folder with all resources, so please do visit that. And we look forward to seeing you in the next webinar in November on albinism, and hopefully also prior to that in the interactive webinar that I mentioned on the 18th of September. Thanks, and wishing everyone a good evening and a good rest of the day. All the best.